about cognitive impairment and outcomes. And it's something we all see in the clinic. It's an important factor. I'm just wondering whether both from a clinical perspective but also from a clinical trial perspective, in terms of I think whether that is something we should be actually capturing as well.
So we've run a trial. Samaya, who was on that photograph, she is Chris Parish's a PhD in psychology. So Samaya ran a pilot study of about 30 odd patients. And what she did is she developed a cognitive assessment tool and ran it with the patients and their spouses. And therefore it has a control group, a relatively age-matched control group. And there is significant differences in the readout of this tool. I don't want to give away the results because it's going, Samaya has presented this at BSH. And there's significant differences between myeloma and their age-matched contemporaries, shall we say, which deteriorates in some of them significantly with, we suspect, dexamethasone. So what we need to do now is move forward and say, well, how does it work in relation to the frailty score assessments we do, etc. This tool is actually quite easy and straight. It's easier to do than IADL and ADL measurements. So potentially it could be an add-on, but we're way short of being able to say that. The neurocognitive imaging is something that we're just getting into, although Andy Scarsbrook, who's an academic radiologist, is going back looking at, he can reinterpret the PET scans at diagnosis. So we're going to be able to actually look at some of that work in our patient cohort running through.
Jonathan.
Thank you very much. One of the things that was striking about the trials is you've got this sort of contrast and disconnect between the academic trials, which have got frailty indexes like built into them, and then some of the industry-led registry trials like the IMROS one, where we were just commenting, there's a lot of DEX, there's lenalidomide 25, there's bi-weekly Velcade. What's the reason for that? And that's obviously going to have implications for how it's prescribed once it comes down on license. What do you think the reasons are for that, and how can we sort of overcome that?
It's pretty straightforward. When industry are running a trial, they are looking to license their drug stroke combination. And therefore, they want the best players in it to minimise toxicity in the older, less fit patient. As a consequence, you end up with SBC-driven drug dosing and delivery. That's how they need to do it to get the regulatory approvals. Academic trials try to answer questions that industry are not able to, or it's not in their clinical development program to do that. So I see both as being important and complementary, provided we still get the funding to do those academic trials to answer the questions that we need to answer. But that's why, it's because they can't afford. The irony is that they will get a license and regulatory approval to deliver the drug or combination in a real-world population, including the people that are excluded from the trials. And that's what we see in our clinics time and time again, having to dose modify, picking up toxicities that were fairly underplayed in that New England Journal of Medicine paper. But that's the problem. The clinical trial run in that context is the imperfect population with the perfect data set, whereas you and I work in a world with the perfect patient population and the imperfect data set. So it's that disconnect. When you look at it across the myeloma spectrum, not just in the older patients, about a third of patients are not eligible for your standard industry trial because of inclusion and exclusion criteria. That third rises to 48% in the transplant and ineligible population. Quite a disconnect, isn't it?
I mean, do you see that as a challenge in terms of, obviously it's got to go through the process of nice approval and so on, that maybe it's not going to be such nice because they've got an age policy, so they won't be able to include it within the NICE appraisal, I suspect. But NHS England, who actually do tend to apply the BUTAC criteria, often based on the trial inclusion, that we might find ourselves in the unfortunate situation that someone who is 80 years of age, who's completely fit, is unable to access an effective therapy.
That said and done, and I'm not here to bash our industry colleagues. Charlotte and I have found J&J Innovative Medicines in our discussions with IFIT to have been really good and really open-minded about our entry criteria, etc. So it's a collaborative partnership, so it's not the traditional IIT funding model, and maybe that's why we're having a different experience. But at the moment, I think it's safe to say, Charlotte, it's been relatively encouraging, hasn't it? We'll see.
Can I just encourage those of you, I'll come to you a second, quickly, online as well, just to submit some questions on the Q&A, please do pop some on there, but I'll come to you next week.
Thank you, Gordon. That's a great talk. Very good, thank you. And very apt, because as we look to the future, I think frailty and all the issues around assessing it, evaluating it, and the impact of our treatments on frailty is going to take centre stage. My question is about our frailty scores that have been drawn up on the back of many trials that utilised the regimens that we had 5 to even 3 years ago. And as we move forward, perhaps with our newer regimens, although you did show the DRD data, as we incorporate bispecific antibodies or stratified treatment, perhaps limited duration treatment, do you think we have to reevaluate how we assess frailty and our frailty models?
Yes, I mean, because of limitations of time, I couldn't really go into immune health, but I think you're absolutely right. I mean, the IMW frailty score is 9 years old. It was a great start, but I think we've got space to modify it, and particularly when you get into eras of really targeted biological therapies like immunotherapy, we do need to incorporate a level of immune health in that. We're still doing that work going forward. We've got quite a lot of translational work coming through from fitness that might start to answer some of that. And then Charlotte and I are building in quite a lot of translational work into iFit that will hopefully bounce on from that and nail it, so to speak. But we're going to have to do something. Particularly, you know, it makes sense, doesn't it? You're going to use an immunotherapy. You're really going to need to have a measure about the aging immune signal. And there is quite a lot of evidence that that signal can be quite impaired in newly diagnosed myeloma patients.
So with immune health, the immunotherapies that we use, they might improve immune aging and the implications of that. But the other point is that the regimens, and Jamie talked very nicely about proteasome inhibitors and IMiDs, the toxicities of those regimens are not insignificant in terms of the impact on the outcomes of our patients that went into those frailty modelling. And so perhaps the impact of some of our frailty scores and modelling will not be as great as we move into the era of immunotherapies as so much that are better tolerated.
Possibly, but I mean, each time we've moved through a new phase of drug development, we've opened up sort of, dare I say it, on target but off tumour side effects. And with that, I still think that physicality is going to be a major part of that. Immunotherapies, we know about the longer term risk of infections with immunotherapies, the upfront inflammatory toxicities in the populations in the trials have been pretty okay. That's not to say that will be the case if you give it to people who are older and less fit with less good immune health. We just don't know. So I think at the moment I'm a bit open-minded about that. I think each new era of drugs brings new toxicity challenges.
I want to bring our panel into the discussion now. So we've got Kerry, you all know well, from Cardiff, Jenny, who's in Bristol, and Guy, who's in Birmingham, just to get a bit of a perspective on the management of frail elderly patients. And so let's start with you, Kerry, in terms of that, kind of following up on Cree's comment around the use of newer therapies. What's your own experience so far in terms of using some of the newer agents in this population of patients?
Thank you. So we have had quite a lot of experience using bispecifics in Cardiff so far. I think the oldest patients we've treated are between 75 and 80, and we haven't yet treated someone over the age of 80. But I think, going back to what Gordon said about age not being the best marker, I don't think that would put us off if we had an otherwise fit patient. So I think there is definitely a role, but assessing the patient as a whole, the impact of their comorbidities and exercise capacity at the beginning is really important. I think when I think about dosing older patients, it's kind of this dichotomy between, are they a patient where I would start at a higher dose and work down, or are they a patient where I feel as if they need to start at a lower dose and if it goes well, increase? And that's something that I think is quite subtle, but we do it in clinic based on all those factors that I've mentioned almost subconsciously.
Obviously, we'll hear Ash about some of the results from fitness, but do you think it is going to ask you this, Gordon, in relation to this whole concept of preemptive dose modification versus going at full dose and reduce? Do you think it is agnostic of the treatment that we use? In other words, it doesn't matter if it's drug X, Y, Z or drug A, B, C, or do you think it is specific to the regimens that we use as to whether or not we should be going for that more attenuated dose in the first?
It's a bit related to Quee's question, really, and I think it's a bit of both. With each new sort of treatment combination we emerge into, I think there are toxicity challenges. And yes, we may need to actually escalate, as Kerry says. In actual fact, in fitness, we escalated and de-escalated treatment. So it did fluctuate depending on people's tolerance. And I think it is really important. Bispecifics-wise, we run our bispecifics in ambulatory care service, except for the over 80s. That we've done a few over 80s, but we actually do that, and bring them in and monitor them, and they've been fine, to be honest. Nervous when I gave the first one, it was 83, but they've done fine. So I think we've got to be a bit more personalised in our decision making. And just one other point to raise, I don't mean to hog this discussion, because then it's not discussion, is it? But it's about using a frailty score. So I was involved in a global project where we recruited real-world patients called the Insight Project, about 4,500 patients. And one of the things we did was we got the PI's colleague to do the IMWG frailty, the full frailty score, ADL and IDL. And blinded to that, the PI was then to use their clinical judgment to decide fit, unfit, and frail. The concordance between the two was nearly 80%. So a lot can be put onto clinician experience. And by clinician, I mean clinicians within the team, not just medics, nurses, all the way through. But that experience is really important. So I think we need to be mindful and incorporate that going forward.
And as clinical judgment, you mean what they're like when they walk into the room? Yeah.
Yep, that's it.
Well, that leads me on that, perhaps to bring you in, Jenny, to the discussion in terms of, you're in your own practice in terms of assessing fitness and frailty and how you see that works, whether you pursue a more formal approach or maybe more of a, how quickly you can get out of the chair from the waiting room into the clinic room approach.
I think we would like to do more formal testing because it's nice to have that objective measure, but to be honest, it's a matter of time in clinic, and our clinical nurse specialist would like to do that, to have that objective measure, but we're more following our clinical judgment. There's a couple of other things though that sort of play into the decision making about some of those treatments. I think a lot of it to do with social support and patient preference about attending hospital. Having DRD, for instance, I think you can easily sell that because the data are so good. But with all the uncertainties of bispecifics, and especially relating to infection risk in the future, in a very elderly person, you may be setting them up for quite a difficult time when in fact, it could be having a treatment that you can be almost certain is going to work with a good improvement in quality of life. So, but again, in terms of the dosing, I think repeating frailty scores or keeping a constant look at their performance status and how they're coping, and increasing doses is really important if you're starting low and going up. I don't know the answer to which is the better option, if I'm honest. I think we do probably a bit of a mixture.
And you alluded to, actually something Jamie alluded to in his talk earlier today around, we examined DRD, but as a continuous therapy, and actually a few years ago we were using fixed dosing, whether that's in the transplant or indeed in the non-transplant population as well. And I don't know, Guy, from your perspective in terms of the conversations that you have with patients in the clinic and taking account of Jenny's comments there about patient preference, how do you take that into account in decision making?
Yeah, it's absolutely critical because obviously quality of life is the aim for a lot of patients rather than quantity of life. And I think that sometimes when you look at the published trials and the scheduling of treatments, you do wonder how accurate the dosing is and the scheduling, particularly things like biospecifics. We all know that we started off with Velcade twice weekly and moved to once weekly subcut. And I think this is really pertinent for an elderly population. I think steroids are a massive issue, and a lot of the toxicity we see is steroid related. And you do wonder about trying to have very low doses of steroids or aiming to look at trials with steroid-free regimens in the future. But I do worry about the scheduling, particularly of the BITE antibodies. I think the toxicity is very cumulative. You can see that with patients that over time they develop infections, and yet you're giving them this continuous weekly treatment. So I think going forward there needs to be better evidence trials to look at scheduling of maybe less frequent biospecifics, for example. I do worry about the trials using biospecifics with daratumumab and lenalidomide. How are we going to identify that fit elderly population, what toxicities we're going to see in that group. But obviously those studies need to be done.
And as people are living longer, obviously with the highly successful treatments, you presented the slides, Gordon, regarding the possible signal of second malignancies using combination chemotherapy, monoclonal antibodies in newly diagnosed. Do you think that's a real signal? Is that something we need to be concerned about? People live for 10, 15, 20 years?
I think it's something we should be cognizant of and make sure we study it properly. We've got, again, John Jones has done that successfully through myeloma 11 and is doing it through myeloma 14 as it reads out. So we'll get a better handle on that, and we will continue to do that moving forward into myeloma 18. So I think it's something, but you've got to bear in mind the population, that the risk of cancer in that population per se is much higher than the younger population. So it's looking at in the context of normalised rates of cancer development. We'll see.
Can I ask a question that is slightly related to what you said, Guy? In terms of trials that we have, most of those are treatment until progressive disease. And it seems that we lack trials that tell us if there is room to stop treatment once you reach a certain point to prevent accumulation of toxicity and then perhaps restart treatment in the future. Do you think that's a useful goal to have in future trials?
Yeah, Jamie alluded to it this morning, that patients don't have a treatment-free break now. They start from day one and they're on continuous treatment for the rest of their lives. And I'm sure that's not right for an elderly population. You get toxicity, they have toxicity, and a lot of our patients are very stoical when they come to clinic, but in reality, when they come off lenalidomide, they know there's a difference, they feel a lot better, they're less tired. So that's what we need to aim for. Maybe obviously MRD is the sexiest thing on the planet at the moment, and maybe that would direct us to stopping treatment, particularly with these novel regimens, we may see more MRD negativity.
I think that could actually be a really good real-world evidence project, because I'm sure we all have in our practice patients who just ask to stop. And I was sitting here wondering whether that's more common in the younger patients or the older patients. And actually, I think it's split between the two. But if you did that and looked at what happened to them afterwards and also what they were like at diagnosis, then you might get some really useful data without actually having to run a study where you arbitrarily decided when to stop, because I think that's the problem. Knowing when is safe is tricky.
It's a very common question that people ask nowadays in clinic, is that, am I going to be on this treatment forever? And
I think it's because they don't like the response until progression or toxicity, and they're just looking for a way out that, when we hit endpoint X, we will stop, and we don't have that. So yes. I think that comes from a bit of anxiety around the unknown.
Great. Thank you. Well, thank you, Gordon, and thank you to our panel. It's been a really interesting discussion. And just to remind you, we're going to rejoin at 1:15 for the AGM. That Kerry and myself will be presenting with the afternoon session following on from that at 1:30. So again, please do try and rejoin. Thank you very much.